Would the clerk please take attendance?
Chair Vanderwall,
Present.
Representatives Thompson,
Yes, present.
Meerman,
Present.
Tisdall,
Here.
Bierlein,
Here.
DeBoer,
Here.
Preston,
Here.
Schmaltz,
Here.
St. Germain,
Here.
Bonac,
Here.
Frisbee,
Present.
Witsit, Carter,
Here.
Whitwer,
Here.
Neely, Hoskins,
Here.
Foreman.
Here.
Mr. Chair, you have 15 members present. You do have a quorum.
Thank you. Clerk, Representative DeBoer moves to adopt the minutes of the February 19 meeting. There being no objection, the motion passes. Today we are going to be voting on House Bill 4032, which we heard testimony on last week. We will also be hearing presentations regarding the 340B program from the Michigan Health and Hospitals Association as well as PhRMA. And if there is a time at the end, we will hear from a few other guests. Oops, that's what's going on. Sorry. Good thing I got a good loud voice, right? We'll hear a few other guests from Michigan Primary Care Association. The first thing on the agenda is 4032. Representative Schmaltz moves to report House Bill 4032 with recommendation. Would the clerk please call the roll?
On the motion to report, Chair Vanderwall,
Yes.
Representatives Thompson,
Yes.
Meerman,
Yes.
Tisdall,
Yeah.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz,
Yes.
St. Germain,
Yes.
Bonac,
Yes.
Frisbee,
Yes.
Witsit, Carter,
Yes.
Whitwer,
Yes.
Neely, Hoskins,
Yes.
Foreman.
Yes.
Mr. Chair, you have 15 yeas, 0 nays, 0 pass. The motion prevails.
Thank you, Madam Clerk. House Bill 4032 is reported with recommendation. Now we will have a couple presentations. Before that, I want to make it clear that this is testimony, is not in regards to any legislation before the committee, either from this term or last term. It is my intention to hold educational presentations over the next few months so our committee members, especially those new to health policy, may begin to learn the issues more in depth. To this point, I wanted to provide a first opportunity to hear about the 340B program early in the term. Given its recent relevance both in the state and national level, I also want to reassure anyone watching that this will likely not be the last time this issue is discussed, and there will be future opportunities for testimony on the topic. With that, we are going to going to our first folks that are going to present here. We have the Michigan Health and Hospital Association. They have with them two representatives from each of their two hospitals. From McLaren, we are joined by Senior Vice President of Government Relations, Deidre Wilson, and their Vice President of Corporate Accreditation, Maureen Diasago. From the Memorial Healthcare, we are joined by their Associate Vice President of Advocacy and Government Relations and Business Development, Mr. Ben Frederick, and their Director of Pharmacy, Dr. Joseph Monroe. Please keep your presentation as precise as we can. We're looking at 20 minutes or so, and then we'll go into some questions. And we appreciate you being here. If you guys would like to make your way up to the testimony table, we would appreciate that.
Good morning, Mr. Chair and members of the Health Policy Committee. My name is Elizabeth Cutter, and you all know that I work for the Michigan Health and Hospital Association. Beside me today are, as noted, Deidre Wilson, Maureen D'Agostino from McLaren, Ben Frederick, and Dr. Joe Monroe from Memorial. We are very excited to be here, and we're very thankful for all of you allowing this time to share the importance of the 340B program in Michigan. The 340B program allows eligible healthcare providers to serve their communities in a multitude of ways, but we're going to focus on what it means for your local community, for your residents, for your neighbors, and for you. The 340B program is an essential safety net program that supports access for vulnerable communities and healthcare providers that care for them. It was created as a bipartisan element in 1992, specifically to support rural healthcare providers and those serving low-income patients. This program continues to operate in that manner without using any state or federal funding. And I'll repeat, it's a non-taxpayer funded program that supports healthcare in your community. The 340B program allows participants to purchase certain outpatient drugs at a reduced rate, creating a benefit for those local hospitals and health centers, which they in turn use to support life-saving access to cancer care, labor and delivery, nursing home care, community-based care, and low-income assistance programming, and many other issues as well. The program benefit stays in your community with the local hospital who participates. That's funding that's going, again, to care for your neighbors, your constituents, and your loved ones. The program requires heavy regulatory compliance, as well as compliance with arduous and non-legislatively created requirements instituted by drug manufacturers. We're subject to audit and annual attestation. We're prohibited from duplicating discounts or diverting them. We're required to submit extraordinary amounts of claims data to ensure compliance, and we do that so that we can serve you. 340B is more important than ever as drug prices continue to increase rapidly. The cost for a new drug launched on the market is now over $300,000, which is more than 4 times the median income in Michigan. From 2022 to 2023, that was a 35% increase. 340B program participants don't have the revenues that our drug manufacturer counterparts operate on. A Kaiser Family Foundation study found that Michigan was one of only 4 states in the country in 2023 where hospitals had negative operating margins. However, according to public data from the U.S. Securities and Exchange Commission, our drug manufacturer partners averaged a margin of 22.8% from 2017 to 2023, and a combined net revenue of 35 manufacturers in 2018 was over $11 trillion, trillion with a T, and that's almost 10 years ago. Protecting the 340B program in Michigan from manufacturer encroachment puts patients and communities first. It keeps important service lines in our neighborhoods. It means your constituents can receive the care when and where they need it at your local hospital. And for us, that's 24/7. It's every day, all the time, including Christmas. And if you have questions for me, please feel free to reach out anytime, because I live here and I work here, and your local hospitals do too. But with that, I want to turn it to my colleagues to talk about the specifics and what they do.
Good morning, Mr. Chair, members of the committee. My name is Deidre Wilson. I'm the Senior Vice President of Government Relations and Public Policy for McLaren Healthcare, and I have with me here, as mentioned, Maureen D'Agostino, who is our Vice President of Accreditation Regulatory Programs. Before I turn it over to Maureen, I want to echo what Elizabeth said and thank this committee for taking up this important issue. 340B is critical to the work that we do in our communities, which is all of your communities. McLaren Healthcare, because of our geographic distribution and the makeup of our healthcare system, we've got DISH, we've got rural. We have Carmanos Cancer Hospital, which is the only cancer-specific hospital in the state with 340B. And while Maureen is going to give you just a small snapshot of what we do in our communities and what we provide in your communities, we welcome any questions at the end, because we'd love to talk more about what we do with 340B.
Okay. Thank you, Mr. Chairman and the committee, and Deidre, for allowing me to be here today to speak to you about this program. McLaren Healthcare currently has 9 hospital organizations participating in 340B drug pricing program. Carmanos Cancer Center, Carroll Region, Central Michigan, Flint, Greater Lansing, Macomb, Oakland, Port Huron, and Thumb Region. Across the organization, individual entities utilize the savings from this program based on local community needs. Many provide funds for healthcare screenings, additional staff for patient disease management and education, personal items for patients at discharge to maintain a safe and clean environment, transportation services, discharge medications, and prescription coverage. 3 of the McLaren Healthcare eligible 340B organizations, Central Michigan, Carroll Region, and Thumb Region, participate in the Rural Health Clinic program to increase access to primary care services for patients in rural communities. We have 36 rural clinics that participate in 340B. The 340B program works in conjunction with these outpatient clinics to provide expanded patient care services, which may include specialty care, patient drug assistance, and additional provider access. Utilizing savings realized through participation in the 340B program, these clinics allow terminally ill cancer patients the opportunity to receive treatment care. This in turn allows the patient to have constant family support. Satellite sites throughout the RHC program are supported by Karmanos Cancer Institute, a nationally recognized cancer center, which affords patients in rural areas the same level of access to treatment opportunities and advances as patients in the more populated areas. Using dollars that 340B program puts back into the community, medical staff can be employed to monitor patients and provide no-cost health screening services. This is critical for cardiovascular prevention, prenatal education, and support after birth, and nutrition management in the diabetic patients. In the Caro region especially, supporting access to local OB care is critical. Without the support of these dollars, Caro patients would need to drive to other communities to get the care that they so need. McLaren Oakland highlights the importance of a 340B program in our urban areas. A 318-bed hospital in McLaren Oakland provides primary and specialty healthcare services to the greater Pontiac and Oakland County communities. Approximately 1/4 of the population of Pontiac live below the poverty line, which makes the 340B drug pricing program vital in providing the community with proper healthcare services. Oakland has established a free drug program to potentially save lives in the event of a future drug overdose. Narcan, a drug used to treat narcotic overdose in an emergency, is provided to patients in the emergency department at discharge if specific patient identifiers are assessed by the provider. In addition to education around the prevention of a future drug overdose, instructions are provided by a skilled medical professional on the administration of Narcan. The Narcan dispensed through this program purchased utilizing savings from 340B drug pricing program. In 2024, Oakland provided 1,213 boxes of Narcan to patients through the emergency department. Other entities throughout the McLaren healthcare system, such as Greater Lansing and Macomb, also provide free Narcan through their emergency department visits. McLaren facilities offer oncology services not only in conjunction with Karmanos in Detroit, but on-site at each hospital. As the advancement of pharmacological therapies to treat cancer grows, the costs associated with new medications can be a barrier to treatment for patients. Several covered entities with McLaren, such as Oakland, Flint, Greater Lansing, Macomb, Central Michigan, and Karmanos, have established a patient assistance fund in partnership with the health system's internal specialty pharmacy, KSP Specialty Pharmacy. Patients can utilize the Patient Assistance Fund to cover gaps in insurance, high copays, or deductibles to initiate therapy as soon as possible. In 2024, McLaren Healthcare, as an organization, provided 3,870 prescriptions utilizing this Patient Assistance Fund, contributing $1.45 million in funding retained through 340B drug pricing program. We know our cancer patients have food insecurities. So with program savings, we have established food pantries for our cancer patients across the entire McLaren organization and are working on expanding that program for our non-cancer patients utilizing these savings as well. In addition to the Narcan and patient assistance programs, our facilities utilize the savings provided by 340B drug pricing program to provide charity care to the uninsured community members. The goal is to provide quality preventative care to members of the community to prevent more complex medical conditions in the future. Staff may coordinate a blood pressure screening and initiate an anti-hypertensive medication to prevent a heart attack or a stroke long term. Over the past few years, the 340B drug pricing program has suffered a reduction in savings due to the restrictions imposed by the drug manufacturers. These restrictions seek to reduce pharmaceutical companies' contributions to the community care by cutting local pharmacies out of the equation. If a patient receives care at a covered facility but wants to pick up a prescription closer to home, Access to community care should not be impacted by that choice. Currently, 37 drug manufacturers have imposed restrictions, with new companies following suit every week or so. The restrictions have impacted the ability of a participating health organization to continue all previously funded patient care services. Manufacturers' restrictions initially were imposed in October of 2020, and in 2024, McLaren Healthcare saw a reduction of $41 million in 340B savings due to these restrictions. Over the first quarter of 2025, the system has additionally been impacted by a loss of $3.9 million in 340B savings. We urge this committee to be thoughtful in their decision so we can continue to support our communities in their time of need. Without this support, which would cost $0 to the taxpayers, these vital community services will continue to dissipate, driving up healthcare costs because of the lack of community support, which we at McLaren are so proud to give. I thank you for your time and your consideration. Thank you, Mr. Chairman.
Thank you, Mr. Chairman and committee members. It's a pleasure to be before you. My name is Ben Frederick, and I have the honor of serving as Associate Vice President for Advocacy and Government Relations for Memorial Healthcare, which is a 104-year-old independent community hospital that serves a rural region centered in Owasso, Michigan, and rural Shiawassee County. Over 60% of our patients are either Medicaid or Medicare in serving our rural region. Going back to the congressional report language, which accompanied 340B's origination, the purpose of 340B was established to, quote, stretch scarce federal resources as far as possible to reach more eligible patients and provide more comprehensive services, really speaking to a general support for hospitals and a recognition of the safety net nature of hospitals like Memorial. Drug manufacturers have to provide and participate in this program to participate in Medicare and Medicaid. Again, further emphasizing that the need to support the hospitals is paramount in the origin of this program. 340B has been utilized by our independent hospital to preserve our existence as a safety net hospital serving our communities. We are the only hospital with a behavioral health unit in our county. We are the only hospital provider with an obstetrics unit in our county. We hold a trauma status, which is not a margin generating status for us to ensure proper care. We also have been able to, through the utilization of 340B program benefits, had the provision of cancer treatments within our county. Something of a personal nature to me and my family in recent years. Our cancer center, our freestanding cancer center on the campus, is only less than 20 years old and is a strategic investment that was made possible in part by 340B program utilization. This allowed my father, when he was on a terminal cancer trajectory, unfortunately 2.5 years ago, to receive cancer treatment where he lived. In a community of under 15,000 people, which is truly a remarkable thing. And as a lifelong resident of Owasso, I think it's fair to say that people deserve access to care no matter where they live. And access to me is defined very much in part by proximity. Prior to 20 years ago, you would have had to drive 45 minutes to an hour to access basic chemotherapy services. In my father's case, palliative chemo. Some of those appointments for pack pulls might have been 15 minutes in duration, with a 45-minute hellish drive there and back. Just absolutely miserable. As it was, my dad was able to access care 5 minutes from his home. My mom was able to be there, and when she got tired from some health problems of her own, she was able to go back home because it was 5 minutes away. That was access, and that was 340B in our community. It's important to differentiate margins, as Elizabeth did initially, within the parts of the healthcare continuum. In 2023, we were happy to have a 0.6% margin coming out of some of the challenges of COVID, as many of our peers were very much in the red. 0.6% was quite an achievement. As we look at 2024, we're hoping for further improvement, but living in the 2 to 3% annual margin is considered to be a pretty good accomplishment in the healthcare provider space. We simply have different functions and different purposes than the pharmacological part of the sector. I think that's important to note. You have different motivations, you have different missions as publicly traded for-profit entities. As a nonprofit entity, our shareholders are our communities, and our motivation is to provide and continue to create sustainable access to services in our communities. Simply different purposes. 340B is absolutely essential in our ongoing sustainability as an independent rural serving hospital. And I just thank this committee so very much for taking a robust, holistic look at this program and its impacts. Joining me to speak more about 340B specifics is Joe Monroe, who is a doctor of pharmacy and also serves as our director of pharmacy and 340B compliance team leadership.
Thank you, Ben, and thank you, Mr. Chairman and committee members. As an independent rural disproportionate share hospital, Memorial Healthcare is a safety net provider, ensuring local access to critical healthcare services for our patients. The program, as Elizabeth was mentioning, was created by Congress to allow hospitals serving a disproportionate share of Medicaid and Medicare and uninsured patients to stretch scarce federal resources to reinvest those into patient care and community health programs. These savings are essential to maintaining quality local care in rural communities like ours. So hospitals like Memorial use 340B savings to expand access to essential services, reduce health disparities, and invest in the well-being of our communities. If this program were further restricted or cut, some of those who would suffer the most would be seniors needing local primary and specialty care to manage chronic conditions like heart disease, COPD, and diabetes. Patients needing rural maternity care would also be forced to travel further for prenatal care, pregnancy services, and labor and delivery. Cancer and infusion patients relying on our rural oncology and infusion center for chemotherapy, infusion therapy, and cutting-edge clinical trials. And then patients with complex diseases like multiple sclerosis, epilepsy, to name a few, who need access to local diagnostics, specialty pharmacies, and infusion services without the need to travel to urban centers. And then finally, low-income patients and uninsured patients who rely most on hospital-funded charity care, medication access programs, and community wellness initiatives. Beyond patients, entire rural communities would suffer from service cutbacks, job losses in healthcare, and reduced economic activities if hospitals like Memorial could not maintain financial stability. 340B allows us to not only to reinvest in patient care, but also in the communities that we serve. So to qualify for 340B, hospitals must meet strict federal criteria to participate, including often hospitals such as Memorial also operate on razor-thin margins due to continued cost pressures in rising prices and inadequate reimbursement. So as a rural independent dish hospital, Memorial meets all these requirements and uses 340B to sustain care where it's needed most. 340B savings has allowed hospitals to expand access to comprehensive local care by funding specialty care for seniors and chronic disease patients. Expanded, again, rural maternity care and pediatric services, cancer and infusion center and clinical trial access, and then maintaining financial stability and expanding low revenue but essential services like funding charity care, keeping emergency departments open despite low reimbursement rates, and then supporting low revenue but essential services like behavioral health and palliative care. For oversight, hospitals in 340B must adhere to strict compliance regulations that ensure savings are used appropriately. We have to perform very intensive monthly internal audits. We have external regulatory consultants come in and perform an annual audit that would follow the Health Resources and Services Administration regulations. And then we're also audited by HRSA. They require hospitals to track every prescription, improve program eligibility for every patient. Severe consequences for noncompliance exist, including manufacturer repayments up to program dismissal for any identified errors or discrepancies. This level of oversight ensures transparency and program integrity, countering any misconceptions about 340B misuse. And then finally, hospitals, especially independent rural dish hospitals like Memorial, are facing severe financial pressures, including rising drug costs that make it difficult to maintain rural specialty services. underfunding by Medicare and Medicaid, which reimburse well below the actual cost of care, and then losing funding that would otherwise be reinvested into critical community health programs. So without 340B savings, hospitals cannot continue to provide essential care at current levels. For Memorial, the program is not just about extra revenue, but it's about viability in stretching these scarce federal resources just as the program intended.
Thank you all for being here and your testimony. We will now go to questions from the committee. We'll start with Representative Thompson.
Thank you, Mr. Chair. Thank all of you so much for coming and for sharing this information. I truly appreciate hearing about what you're doing to reinvest in our most vulnerable communities. This question is either for Elizabeth from the Hospital Association or from anyone who would like to answer. I think you might be a little bit more able to answer it because you represent multiple hospitals. What I would like to know is what is going to happen to this life-saving treatment and to all this charity care programs that you are doing under this if drug manufacturers continue to restrict your ability to use this funding?
I'm happy to lead, and then I may turn it over to my colleagues to speak on the specifics of what they're already experiencing. So I think what we continue to hear from our members is that every single time that there's a new pressure put on the program and a reduction in overall program benefit, there are real harm and reductions to being able to offer services. So when you ask, what happens, what's next, if someone says 340B helps make sure that we can offer obstetrics and gynecology in a rural community, if we no longer have the benefit, that goes away, unfortunately. And it doesn't go away just for patients who are eligible or for eligible 340B hospitals, it goes away for that whole community, which is a really serious risk and a real reason why we care so much about this. But I would turn to my colleagues. I know, Ben, you've shared on multiple occasions what this looks like from an annual basis for you all. These are real reductions that are happening right now and real decisions that we have to make on service lines that we offer right now. And that's not unique to just all of us sitting here. That's to every of the 86 hospitals that participate in the program currently.
Yeah, I would like to speak to the rural OB because I think that's a really critical point and one that is not just unique to Michigan or not just unique to McLaren. It is a national issue. And as Maureen mentioned, as we face $41 million of cuts in 2024, I take a look at our rural OB program in Caro as a perfect example. Already a difficult program to maintain. If you can believe it, that program servicing 9 counties does more births in the Thumb region than we do in Flint. And so if a program like that is eliminated, the next closest location, 90 miles away, certainly can't take on that influx of patients. And you see this trickle-down effect through the entire system, not just that specific 340B location, but the roll-down effect for the entire healthcare system and the various communities we serve. I look to cancer. It's one we can speak, I think, the most to as an NCI-designated cancer center, one of only 2 in the state, us and University of Michigan, but the only cancer-specific hospital in the state. We're able to offer a $0 copay to certain recipients of cancer care, wildly successful, as you can imagine, but not just because they're not paying those dollars. They're getting the care. They're getting a critical cancer treatment that they otherwise couldn't get. And to think about the impact of what that might mean and the trade-off for an individual that can't receive that kind of care would be devastating.
I would just say briefly that to Elizabeth's points, we see trajectories with things. We've seen an increasing Medicaid-based caseload, so the numbers start to get to a certain point where you start looking at where do we have a challenge with continuing our level of present access. We have programs like a bridge coverage for cancer treatment so that patients can start their cancer treatment immediately. Rather than waiting through a prior authorization process, we front that so that treatment can happen right away. And we also have been able to do things strategically with providing additional primary care access in rural communities around us. And we're continue to be under a primary care and behavioral health care federally designated shortage area. And those are areas where we strategically look to find ways to provide additional access to primary care. Again, one part of access is proximity, the other is wait time. And if you have a 6-month wait time to get into a primary care, I would argue you don't have access. So those are areas we try to tackle. Our program implications on reductions is around the neighborhood of about 8.5 million. That's all scalable, obviously. That's tremendous. And in the particular part of 340B affected, it's an 80% reduction of our capacity to continue to preserve that access.
I think I would just add one other thing. I mean, it's not conjecture to tell you that hospitals close when 340B goes away. I mean, we had a hospital in Ontonagon that closed because they couldn't keep their 340B status if they converted to a rural emergency hospital. That's a real and very significant issue. That's a community that no longer has care, and that impact is directly correlated to 340B.
Representative, that answer your question?
yes,
Thank you. Next, we'll go to Representative Meerman.
Thank you, Mr. Chair. Do we have numbers of where this 340B program has gone? 1992, so let's pick 2000, let's pick 2010, let's pick 2020. What has happened to this program over that? What kind of graph does that look like? Because in essence, we're moving money from one part of a healthcare pool to another, trying to make it more affordable for some people. So that's my question.
Yeah, that's a good one. I think our colleagues from the manufacturers will likely talk about this too, but it has increased. I would tell you that the overall increase in 340B from 1992 to now too is also pretty correlative to the increase in cost of drugs. So the program itself relies on and is predicated on what the cost of drugs are. If the cost of drugs increases, the program increases. As we noted, I mean, drugs increased over 35% just in the last couple of years. So yes, it's increased, but so has the cost of drugs.
Just a comment, I guess. I mean, the pool is finite. We can't continue to pull more from it. We got to make sure it stays within its scope of just that drug support that certain communities need.
Yeah, I would just highlight too, it's only outpatient drugs and it's only certain identified outpatient drugs, so it's not every drug.
That answer your question, Representative? Or sort of?
I've always got more questions.
Yep. I think I'm just going to quickly interject and ask a follow-up because it pertains to Representative Meerman's, and maybe he was trying to get to this and we didn't get the answer. My question would be, sitting on the outside looking in some of the issues that people bring forward, is the growth of the program might not always be the dollars that have been put into it. It's how many new 340B facilities have joined into that program above the scope that originally was started in 2020. I'm just looking in the last 4
Sure.
years.
I would highlight in 2010 the addition of a couple of covered entity types. That's the last time we had expansion in terms of who was eligible, and that was inclusion of things like critical access hospitals, rural referral centers, and sole community hospitals, which fit squarely in the intent of what Congress wanted, to serve rural communities and underserved communities. So adding those additional eligible entities would have grown the program because more were able to participate. But those are hospitals that are directly within the bounds of what Congress intended.
Representative Meerman, quickly.
Yeah, thank you. So how do we know these people utilizing this? We talked about some fines and stuff over here if you don't. A 340B place, how do we know these people qualify for that?
Claims data. So you are audited based on your claims data. You have to submit your claims data. Oftentimes the manufacturers require us to submit claims data on the 1st and the 15th of every single month to 340B ESP, which is a claims data platform. That data is everything on every patient to make sure that patient has an eligible relationship with the hospital. You have to comply with HRSA's 1996 guidance on patient definition, which actually requires you to have a legitimate relationship with that person, not just like oh yeah, we've seen them and oh, whatever. No, they have to have a legitimate relationship with the hospital. They have to be prescribed an outpatient drug that is covered by the program, and they have to be able to receive that drug either at the hospital proper or at a pharmacy that we work directly with.
Thank you. Representative Frisbee.
Real quick. Thank you. How do you track, the difference between not-for-profit and for-profit may be different. How do you track the 340B savings to ensure that they are then used to not just increase hospital margins, which we're already hearing that hospital margins are next to non-existent. So is there a difference in how they're tracked between for-profit, nonprofit?
I'll let my colleagues answer to that, but it's only nonprofit hospitals.
Okay.
For-profit hospitals don't participate in the program. They're ineligible at the federal level. It is
Okay.
exclusive to nonprofit hospitals.
And we've seen a large growth of for-profit hospitals in Michigan in the last,
And they don't participate in 340B. They are absolutely ineligible in the program.
typical level of charity care percent of your revenue.
I would defer to my colleagues to speak on theirs.
Percent.
We'd have to look at the specific charity care percentage, and we can get back to you. But relative to 340B, I think Maureen could lay out, specific.
Okay, the last question
dollars.
I have, is it reported on your 990s as a nonprofit of community benefit as well?
Yeah, we are required to report our community benefit
Okay.
numbers as well.
Yep, thought so,
Absolutely.
just want to be sure. Thank you.
Thank you, Representative. Appreciate that. Any other comments from the,
I'm sorry, I was just going to say, and we are audited and surveyed against that by multiple agencies.
Okay,
Yeah,
thank you.
to make sure we're doing it right.
Thank you, Mr. Chair.
very good. Thank you. Representative St. Germain.
Thank you, Mr. Chair. You had mentioned Narcan as part of your program. I've had a few constituents reach out who are struggling to afford EpiPens, and I wondered if your program covered EpiPens for patients.
We can definitely do that. Of course, they have to meet the criteria, as you've heard. But we, an EpiPen, if ordered by the provider, we can certainly make that happen. So depending on the drug and what we're doing out in the community, sometimes we do that EpiPen out in the community versus them coming to the hospital, so at a fair or something like that. Yep.
Very good. Thank you. Representative Foreman.
Thank you all for this information. Just help me understand something. So especially the fact that drug manufacturers have a profit margin of like 22%. It sounds like pharmaceutical companies are continuing to place like more arbitrary restrictions on 340B. So I just want to understand, at the end of the day, do these restrictions increase their profit margins? Thank you.
It's pretty black and white. I mean, it's either back to the margins of that part of the healthcare continuum, or it's to the benefit of the safety net providers. And I don't say that to be glib. It's just truly a fact. The intention of Congress was to supplement what I think they recognized was going to be chronically underfunded CMS-based reimbursement with a highly profitable part of the continuum that is contingent on still the prescribing behavior of the healthcare providers themselves. So again, we have different functions within that ecosystem. But the short answer is it really is that clear cut. It's there or there,
Yeah, and if I could just add on to that, yeah, I think Ben is right. They answer to shareholders, we answer to our communities, and this sort of like term discriminatory practice, because that is what it's sort of being deemed as nationally, as we're seeing swaths of legislation come forward in various states and been successful in states to stop these practices because it does not meet the partnership intent, I think Elizabeth mentioned, of the inception of the program. Those practices are to find a way to provide less, not more, and the ultimate impact would be more, perhaps, to them.
Thank you. Representative Bierlein.
Thank you, Mr. Chair. A couple questions, if I may. First one, so 340B, it's the federal regulations. It's obviously happening in other states. How are other states handling this?
So I think it depends. I will approach the question from one of the issues that we're currently facing with our members, which is restrictions in and around how many pharmacies you can contract with. Currently, there's legislation introduced in 17 other states besides Michigan, so 18 total. 8 states have signed into law legislation on that issue particularly. Several of them have been sued by pharmaceutical manufacturers, and those states have won every single time because it is well within the state's rights to regulate the health and welfare of their residents. But we continue to push forward with legislation in that space as well and join our colleagues across the country to make sure we're filling in the gaps that Congress has not dealt with, and we don't anticipate they will deal with anytime soon.
And I'll add one piece onto that. Not only have the states pursued this, and there have been challenges, the United States Supreme Court has denied the challenges by PhRMA to take up the case, and thus sort of supporting that it is within the state's jurisdiction and the state legislatures to look at this very practice and the access that it restricts within the communities.
Thank you for that. And then, if I may, how do you determine when the 340B dollars come in where they're going to go in the budget? Like, what's the process for putting them in different line items and whatnot?
I'm going to defer to my colleagues, but I think one of the primary things that we look at is your community health needs assessment. So as a nonprofit, you're required every 3 years to do a community health needs assessment. That means you go out to your community, you talk to them, and you say, hey, what's impacting you? What's your problems? Like, what are the things that you feel like you have barriers in? Oftentimes, it's things like diabetes, it's heart disease, it's food insecurity, as noted. But you take the community health needs assessment and you look at that independently, and each independent hospital then says, hey, this is a space where we can allocate 340B dollars to make sure that we're addressing what our community is telling us are the problems. That's one of the foundational elements, but I would let Maureen speak on it and Joe speak on it as well, but that's one where we use that information because the community is telling us what they need, and we want to make sure we're responsive to that.
Yeah, community health needs assessment. We're also required now by CMS to collect specific demographic type of information when a patient comes in around food insecurities, transportation. We look at that. Now that we've been doing that for almost a year, we have a lot of data there. But we budget, to answer your question, the expense of the purchasing of pharmaceuticals. We do not budget the revenue side that we would anticipate from 340B. You either got, it's not revenue because an insurance company's not paying us, reimbursing us, but so we'll just call it that, because it changes, as you can tell by the testimonies, the amounts change. So we budget for the pharmaceutical expense, and then what we receive back in 340B savings then goes back out through the community benefit. But it's not a budgeted number.
So I guess with that, though, it's not budgeted, but it's obviously tracked. So if during an audit, we could see where those dollars go.
Absolutely. At McLaren, we do 100% every prescription that is ordered through the 340B program is tracked. 100%.
Okay, thank you.
Representative Bonat.
Thank you. Elizabeth, you mentioned the closure of the hospital in Ontonagon. Could you review the reason for the closure, and was it because of loss of a 340B status?
So it's a little bit more nuanced than that. They were a hospital that was struggling because they are a small rural hospital serving a small community. Obviously, they're an incredible benefit to that community because having a hospital near you means, to Ben's earlier points, you're not traveling 2 hours plus for any type of different care. They looked at converting to a rural emergency hospital, which is a new classification of hospital within probably the last 3 years. That recognizes that, especially in rural healthcare spaces, you may have volume concerns, you may have reimbursement concerns that you can't support, and it helps you be able to transition that into a rural emergency hospital and then stay open. The difficulty is a rural emergency hospital is not a classified eligible entity for 340B. So while they were a 340B hospital when they were open, when they wanted to convert to a rural emergency hospital, which is the only space they would have been able to stay open as, they no longer could be 340B, and that loss meant they couldn't convert and couldn't stay open, and instead they just closed. We have been working with our congressional partners to add rural emergency hospitals to the 340B statute because they are becoming really integral to our ability to protect rural access.
Thank you.
You're welcome.
If I could, Mr. Chair, just very quickly on that question.
Very quickly, we got one more presenter yet, and
Just from
another
the
one that
st-
would like to speak.
You bet.
so.
From the standpoint of another rural independent, I could say that deterioration or loss of 340B would be a primary determinant of our ongoing success as an independent hospital. I mean, that's not an exaggeration. It'd be a primary determinant for us.
Thank you. Representative Preston. You're good. Very good. All right, with that, I will say I appreciate you being here. And as we chatted this week already, I would love to have the opportunity to make sure that we could do follow-up, because I know as we become and we hear the next presentation, it's going to spur a bunch of new questions. And I want to make sure that we really spend the time that everybody on this committee feels comfortable. So I will coordinate that with you as we move forward. But again, I appreciate your time out of your busy schedules to be here today and explain a very complicated issue. And we look forward to continuing to work with you and making Michigan stronger. Thank you. Next, we will hear from Kelly Ryan, the Deputy Vice President of State Policy for PhRMA. She's joining us by Zoom. And Ms. Ryan, I appreciate you being here. Again, your presentation, take your time, make sure you deliver it the way that you need to deliver it. We'll do as many questions as we can. And again, I'll state the same thing. We would love to invite you back, because I do know that there's way more questions. I have several that I would like to ask, but I want to make sure you've given up a lot of your day to be here, and I appreciate the testimony table is yours.
Well, thank you so much, Mr. Chairman, and I appreciate the opportunity to be here. I'm sorry I'm zooming in. I'm actually having similar conversations in a couple of states today, but one of these days I really would like to get there and visit you all in person. Very much appreciate the time. I'm going to cross my fingers that I'm not a complete Luddite and see if I can share some slides, not to walk through a real formal presentation, but just to kind of give some visuals. I know this is a really complicated program. The previous presenters did a great job of laying out some of that complexity, and I was taking really good notes so I can try to answer, from our perspective, questions that came up along. So let me see if I can make this work, and we will go with it. Are you all able to see my presentation?
We are.
Still just me.
We can't hear you now, though.
No, it's just
There you
okay.
are.
That's
There we
fine.
go.
If we don't have slide, I have a deck that I will make sure the committee has. Like I said, I wasn't going to follow a real strict structure. I just wanted to give you some visuals given the complexity. So I'll just talk through it and, like I said, provide this resource to you all afterwards, just so you can kind of have some citations and follow up. So, the 340B program, it was described earlier today, was designed as, a safety net program to help certain hospitals, federal grantees, FQHCs, clinics, exactly as was discussed earlier, stretch scarce federal resources. That's the line in the statute, right? There's not a lot of detail about what that means. And so the program came out of essentially an unintended consequence from the Medicaid drug rebate program, because manufacturers were providing discounted medicines to these safety net providers before the Medicaid drug rebate program. And then the way that program went into place, there were some questions about whether or not manufacturers could still do that and not run afoul of best price. And that was never anyone's intent to, get in the way of those rebates. Or those discounts. So, the 340B program came very quickly after the MDRP to sort of close that gap. And it was designed as, a small safety net program, but it has changed really dramatically, and it has become the second largest federal drug program. So that's bigger than spending in Medicaid, Part B, VA, TRICARE, Department of Defense spending. It is second only to Medicare Part D, and it is a $66 billion program. That's the discounted purchases. That represents a 23% year-over-year change from 22 to 23. We see this consistently about 20+% year-over-year increases. That is while, net spending on medicines has stayed a relatively stable share of the pie. It's about 14%. Increases in medicines have been at or below the rate of inflation for well over 5 years. And so when you look at that stability on one level and 20+% year-over-year increases, even with some of the manufacturer guardrails on the program in place that were discussed earlier, we are still seeing this kind of increase. So just a little bit of context there. And hospitals account for 80% of all program purchases. So, the clinics that are part of the program are an important piece of the program, but take up a small piece of it. This growth has not been commensurate with gross and charity care. So just sort of looking nationally, 69% of 340B hospitals provide less charity care than the national average for all hospitals. In Michigan, and we can share this data, again, on average, charity care accounts for 0.9% of total operating costs at 340B programs hospitals in the state, and 97% fall below the national average of all hospitals, which is 2.5%. I want to be clear, you heard some of this earlier. There is, really important work being done. There are safety net providers that are doing really good work. You heard some of these programs. And PhRMA and the industry supports the original intent of the program. However, we have some real concerns with problems that have arisen in the program. The program is absolutely broken. There has been a lot of conversation at the federal level at this. And what we're seeing in state legislation is proposals that would lock in some of these problems into state law. And that's really where we have a lot of concern. So one of those problems, which I'll talk about in a little bit more detail in a minute, is the exponential growth in the number of contract pharmacy relationships that 340B providers have. Another thing we're seeing, we're just talking about this a little bit earlier, keeping track of claims data to make sure that, HRSA is auditing properly, that manufacturers can audit, that, the system is running as it should. There are bills out there that would not only prohibit the use of a claims modifier so that the system all the way kind of through the processing can recognize whether a claim is a 340B claim, whether it is a Medicaid claim, which it's actually illegal to have duplicate discounts in both places. So there's legislation, including in Michigan, that would say, hey, you can't even check the box and identify that it is a 340B claim. And to take it even further, we're starting to see language that would completely prohibit the use of broader claims data. So all of that great information that was talked about earlier, that's important to feeding into audits and the integrity of the program, there is state legislation that says you can't use any of that. So we would have a concern with language like that. And, the one slide I actually do really wish could show it. We have a great one. And like I said, we'll share it with the committee that visually walks through in a really simple manner how the sort of the dollars flow in the program, right? So, but at its most basic, the manufacturer provides the 340B hospital. I'm just saying hospital for simplicity. It could be a grantee, an FQHC, a Black Lung Clinic, never. But so, manufacturer provides a 340B hospital with discounted medicine. Assuming a 50% discounted price, the average is about 57. So in this example that we have talking about $1,000 medicine, and the commercial insurer has negotiated a rate with a hospital to reimburse for that medicine at $2,000. So a 2 times markup. That is pretty common and actually a little bit on the low side, but just to keep the numbers simple. So, the discount is provided to the hospital, the patient goes to the pharmacy to pick up that medication. The patient is paying, if patient is commercially insured, the patient is paying whatever his or her copayment is. If the patient is uninsured, there is a chance that that patient, especially if they go to a contract pharmacy that has no obligation to share any of the revenue, is paying the full list price of the medicine when the hospital got a 50% discount. Now, plenty of covered providers have programs, you heard about some of them today, that does start to flow through. But it is not uncommon for an uninsured or an uninsured patient to walk into a contract pharmacy and pay, the full list price of the drug when there's been a substantial discount. And so kind of walking through the numbers, if the drug list price is $1,000, the hospital buys the medicine for $500. It is reimbursed at a negotiated rate, receives coinsurance from the patient. All of that adds up to a $1,500 profit for the hospital. And the question is, A, how is that money being used? We heard some of that today. And B, is that exactly how we want the system to work? And the real concern that we have is applying that system to contract pharmacies. So when the federal 340B program was created, the concept of contract pharmacy does not exist in the statute. It does not exist in regulations. It was conceived that it was the pharmacy at the provider, right? So hospital X is a participant, they have an on-site pharmacy, that's where the 340B benefit works. Very quickly, in the early 90s, HRSA, the federal agency that oversees the program, realized, well, wait a minute, if we have a clinic that we want to be a part of the 340B program, but it's a small FQHC, they don't have a pharmacy on site, they can't take advantage of the program because they don't have a pharmacy. So we're going to allow them to contract with a pharmacy. And so this has all been developed in sub-regulatory guidance. The initial approach was, okay, you can have one, and then you can have a couple, kind of played it out. And then in 2010, HRSA changed their guidance and said, you know what, 340B covered entities can have an unlimited number of contracts, as many as you want. So at the time of that guidance, just to give you all some perspective, the number of contract pharmacy relationships in 2010 was 1,700. The number of contract pharmacy arrangements in 2024 was 212,000. The number of contract pharmacy relationships has grown more than 12,000% since that change. And why is that a concern? There's a lot of conversation about keeping money local and in the system and supporting safety net providers, and that's absolutely the intent of the program. But we know that more than half of 340B profits that are retained by contract pharmacies, who have no obligation to, provide any benefit, they're not the 340B entity. Half of those 340B profits are retained by 4 pharmacy companies, Walgreens, Walmart, CVS, and Accredo, many of which are vertically integrated with large PBMs, for-profit, publicly traded, pharmacy and PBM chains. So we are seeing a significant number of dollars diverting away exactly from the kind of safety net providers that the program is intended to support and, getting spread out away from helping the community. Minnesota has done the first report that really starts to dig into what is happening with 340B and dollars in the state, and we will make sure that you all have this report. It's really illuminating. Their first report is absolutely conservative because the statute did not include physician administered drugs in the first analysis, and they acknowledge this in the report. And those drugs are a big piece of the 340B program, especially in the oncology space, like going into a clinic and getting chemotherapy. So this is an underestimate, and Minnesota acknowledges that. But just a couple points, Minnesota found that third-party administrators and other external parties received 16 out of every $100 generated in gross 340B revenue, right? So going to consultants, TPAs, the folks in the middle, not the safety net providers. And really concerning from my perspective is Minnesota also found that 10% of their grantees, so FQHCs, clinics that are really, doing God's work in the community, 10% have negative net 340B revenue because of payments they're making to TPA middlemen, right? So we know, just looking at data out of Minnesota, that these really important dollars that are meant to stretch scarce federal resources and are meant to help the community are getting diverted from that program. And that is all happening because of this growth in contract pharmacies. And so when we see bills that take this sub-regulatory idea that HRSA came up with that says, hey, you can have as many contract pharmacies as you want, no matter what, and locking that into state law, we have a lot of concern because we see that as fueling exactly, some of these problems that I've been talking about. And one of the other pieces I kind of wanted to dig into for just a second, and then I will stop and happily take any questions, is this idea that, this is just moving money from manufacturers, for-profit entities to the community, and there's no state tax dollars implicated. There's no harm for anyone else in the system. This is just sort of shifting money around in buckets. And we know, and we've seen considerably more data over the last couple of years that is not the case. So there are a couple of things going on. There are a number of reports that show that 340B hospitals spend more on drugs. They use more expensive drugs. There's less biosimilar uptake in those hospitals as compared to non-340B hospitals. And that makes sense if you sort of think about that profit in the middle, or the revenue that is kept in the middle. There is an incentive to make that piece bigger, right? So if you're prescribing more expensive drugs, you're prescribing the reference product instead of the biosimilar, that gap is going to be bigger, and that is going to drive revenue. The North Carolina State Treasurer took a look at markups in the system, specifically at cancer drugs at 340B hospitals, with respect to the teachers, the state employee program, right? So it's a pretty narrow analysis, but it's illuminating. And the treasurer found that 340B hospitals billed state employees an average markup of 5.4 times for cancer drugs as compared to their purchase price. And then they generated $13,600 in profits per claim on cancer medicines. And so it was absolutely driving costs for the state of North Carolina. And we see this in other areas, both in the commercial market and for state employers. Just recently, IQVIA issued a very detailed, very wonky report that looks at just one driver of costs in other parts of the system from 340B. So not this markup, not prescribing more expensive medicines, but just looking at how commercial employers lose rebates, right? So, my health plan negotiates rebates with the PBM based on, claims volume. When the dollars are gobbled up earlier in the system by the 340B program with that average 57% discount, very often those commercial rebates don't happen, right? Because the savings have already been picked up earlier in the program. So just looking at foregone rebates, IQVIA found that prescriptions with 340B pricing increased employer costs by over $66 billion. That's in the sort of the private market, and that state and local government plans by more than $1 billion in 2023. And they did a very detailed analysis, state by state, looked at the volume of 340B utilization in the state. So they weren't just going, okay, here's the population, we're going to divide the number by that. They did a very detailed analysis for each state, and they found that in Michigan specifically, those numbers are Michigan employers pay an estimated $272 million more in healthcare costs because of these foregone rebates due to the 340B program. And that, I'm losing my numbers. And the sort of the next step of the analysis is, those are healthcare costs for employers. So those are non-taxable. And so if those dollars were not wrapped into paying for healthcare, that they were instead wages, that could generate $13.4 million more in state and local tax revenue. And that comes out of an analysis from an organization called Magnolia, which I will also share with you. So this idea that there are not costs to the system because of 340B is consistently being shown to be inaccurate, and it's a really important consideration as you think about legislation that would kind of lock in these problems with the program that is being driven by the growth in contract pharmacies. I will stop there. I'm happy to take any questions and kind of dig in a little bit.
Thank you very much. Appreciate that. We'll turn it over for the first question, Representative Bierlein.
Thank you, Mr. Chair. Can Can you just go back to that IQVIA thing real quick and explain that? That was just more detail maybe so we can understand better what you were saying.
Yeah, absolutely. And, another resource that we can share with the committee, the state of Utah did a really helpful fiscal note exactly looking at this. So if, a contract pharmacy mandate were to pass, what would the foregone rebates for the state employee health plan be? And therefore, what would it cost the state? And they walk it through in frankly a very helpful and simple way. So we'll make sure you have that as well as backup. But the concept is commercial payers, when they negotiate rebates, through their PBMs, those rebates are not happening because there's a duplicate discount on the 340B side. So 340B kind of like takes the savings first. I want to make a distinction in the Medicaid arena. It is illegal to have both a 340B discount and a Medicaid rebate. It's more standard practice in the commercial market, but the same thing happens, right? You get one or the other. And so because of the growth in 340B, the savings are being gobbled up earlier in the process. So the commercial payers, whether it's, a big self-insured plan, whether it's a state payer, or whether it's a small employer buying from their health plan, those rebates are not flowing to that negotiated contract. And those dollars are driving up healthcare costs for folks. And that's where that, in Michigan, it's $272 million. And the state employee number, which I didn't have right in front of me a second ago, and I apologize, is $34 million for state employees based on foregone rebates.
Thank you. So as we continue these conversations, if you could provide those numbers and on paper, that'd be great. Thank you very much. Thanks, Mr. Chair.
Of course.
Thank you, Representative Carter.
Thank you, Mr. Chair, and thank you, committee, everyone. I need to get a little clarity on something you said. You mentioned charity care, okay? Can you give the committee a good explanation of what you meant by charity care? And then can you also answer the 0.9%, I believe you said, of the charity care? I need a little clarity on that.
Yeah, absolutely. And I'll provide our slides as well that have some citations and definitions. So the analysis that we did is based on hospital cost reports and looked at charity care from the perspective of cost of providing free or reduced cost care for patients who qualify for a hospital's charity care policy. So hospitals can have different policies. And I do want to, be clear and acknowledge that it's not necessarily a one-to-one direct relationship from 340B savings to charity care, right? Providers are empowered to do more than just charity care, and you heard about some of those programs. So you don't want to give that impression. But charity care, because it is reported on cost reports, is a good sort of analog to say, okay, if you're not even at the average nationally of charity care, but you're getting lots and lots of 340B dollars, like what are we missing?
Okay, I guess I need just, Mr. Chair, can I ask for clarity? I'm unclear about exactly what you mean by charity care. Now, there's been some great examples of work that's been done, in support of the 340B program. But when you say charity care, I want to be clear on that. Can you
The cost of providing free or reduced cost care for patients who qualify for the hospital's charity care policy from CMS. So there's a CMS form the hospitals have to report, and that's the data that we're looking at just from the charity care perspective. So you're absolutely right, Representative, that there's other good work being done that does not fall into the definition of charity care. I don't want to give the impression that we're not looking at that. Because the language in the federal statute is so general, right? Just like stretching scarce federal resources, charity care, because it is reported to CMS, is the easiest way to have kind of a consistent metric to look across the board, right? And like I said, not trying to give the impression that everything that falls into 340B has to fall into that category. It's one marker to kind of have the conversation around.
Thank you. I appreciate that answer because, it was coming across like that was the only metric that was
Yeah,
being
no,
utilized.
I
and
apologize
it's
if I
not.
gave that impression. That is not the case. It's the easiest, most consistent way to report it. And, you know, if charity care doesn't seem to add up, you know, it just raises questions. And, you know, there is very little transparency around where these dollars go and exactly what has to happen, right? There are, yes, the providers have to account to HRSA for what they do, but nobody's actually reporting, you know, kind of tracking the dollars for dollar, how those flow.
Okay, thank you for that explanation.
Thank you, Representative. Representative Foreman.
Thank you. Thank you, Kelly. My question is, who sets drug prices and how much do your members provide in patient assistance program as a % of your total revenue? Thank you.
Sure. So I work for the trade association, so I actually don't know, you know, percent of total revenue on a company by company basis. That is not something that we don't talk about member specific issues. So I certainly can see if I can find some of that information and circle back. It's just not information that I have. You know, manufacturers do set the list price of medicines, but you know, more than about 50 cents on every dollar spent on brand medicines, for example, goes to players in the system other than the company that researched and develops the medicine. So, you know, PBMs and health plans set what people pay at the pharmacy counter. There are a lot of other players, including the 340B program, that drive what people are paying, you know, at any given stage in the process.
Thank you.
Thank you, Representative. Representative Meerman.
Thank you. Kind of the same question. Can you give me some synopsis of, you know, where we've gone 2010, 2020, 2020, you know, 2000, sorry, start at 2000, 2010, 2020.
Yeah, so like I said, we have seen about 20% year over year growth. So we are at $66 billion now. And, you know, looking at contract pharmacy relationships, which is a big driver. I know you were asking earlier about sort of the scope of the program. That's a big driver of it. In 2010, there were 1,700 contract pharmacy relationships. In 2015, there were 40,000. In 2024, there were 212,000.
So 66 billion now, and then we're backing it down to, I mean, where were we at 10 billion in 2000? Or is that something you got to get back to me on?
I would have to double check that. I haven't looked back that far in a while, but I will, and we'll make sure that I circle back on the size, you know, of the program 40 years ago. But to be clear, it was discussed earlier, there have been some changes in addition to this expansion in contract pharmacy, you know, with the ACA. The previous presenters were absolutely right. A number of providers were added into 340B eligibility, critical access freestanding cancer hospitals, rural referral centers, and sole community hospitals. And what we have also seen driving growth in the program is healthcare consolidation, right? So the way 340B works, if what we would call the parent site is a dish hospital, as they have other sites, those covered lives or those claims get pulled into the 340B program. So there's incentive to buy provider practices. There's incentive for hospital systems to buy a dish hospital, to buy a critical access hospital and bring it into the system. And that is another way that's expanding the program. So I will see if we have any data on that and circle back as well.
Thank you. We'll finish up questioning with Representative Schmaltz.
Thank you, Chair, and thank you, everyone, for being here to testify. You talked about there not being enough transparency to where the dollars are spent. The hospitals track it, it's audited, they have strict guidelines. So where do you think there's no transparency in that?
None of that is publicly available in a consistent manner. There are no federal reporting requirements in the 340B program about how dollars are spent. Contract pharmacies don't have any at all, right? So the hospital may be, pardon me, the hospital may be obligated to be audited by HRSA, but their for-profit contract pharmacy doesn't have any reporting obligations. And, we know that the number of, HRSA is a very small federal agency. So, and again, by and large, folks, providers are doing the right thing. I'm not coming here and saying there's, the whole system is rife with bad actors, but the reality is that HRSA can do a handful of audits a year. We looked at the numbers for Michigan providers over the last couple of years, just to say we've got 86 hospitals that are participating. There were fewer than 20 audits period over the last 5 years that were completed. And all of that information is available on the HRSA website. You can see, the number of Michigan providers and who has been audited. And the numbers are very low simply because the agency is just not built for that.
Or it could be that they feel that it is transparent enough for that. That could be a reason too. Thank you.
Sure.
Thank you, Representative. With that concludes testimony from Ms. Ryan. The same thing goes is that I know we have more questions that I cut off. So I'm asking that if we can reschedule and have you come back again, we would appreciate that. With that, I know that we have another group that wanted to speak today from Great Lakes Bay Health Center. Unfortunately, folks, we're out of time, but I'm going to ask the same thing. Would you be willing to come back? We'll coordinate a date with you. I appreciate you being here. We expected that we were going to have a couple of things like this, that this would take longer. But it's very important to hear what you have in testimony, and we'll schedule that so all of us can come back together. But I apologize for running out of time today. As you know, this is an important issue. So thank you for being willing to do that. With that, Representative Bonack moves to excuse absent members. There being no objection, the motion prevailed by unanimous consent. There being no further business before the Committee of Health Policy, we'll stand adjourned.